Okay. So stent thrombosis, this is a true nightmare for cardiologists. I will present a quick case scenario that we have faced long time ago, but because of the recurrence of this condition and also the high mortality rate, I always like to see again and review this case again, just to keep in mind of everybody, either junior or interventionist or other cardiologist. So we'll start. This is a 45-year-old gentleman. He's a heavy smoker, dyslipidemic, newly discovered diabetes, and he has family history of premature coronary artery disease. He presented on 15th of June 2018 with typical chest pain. He had troponin elevation, dynamic ECG changes. First, he presented to some private hospital. They admitted him to CCU and started medical treatment, aspirin, Plavix, and anticoagulation. But the patient pain did not settle, so they decided to proceed for further management. They sent him to Amiri Hospital for coronary angio and the possible PCI. Upon the patient arrival, he had persistent chest pain, subtle ST segment elevation in inferior veins. So we shifted him to cath lab for urgent PCI. And he had one drug-eluting stent fixed to the LAD, followed by Agrestat for 24 hours. Plavix also was replaced by Brilinta and aspirin, and he was and it was continued for anti-ischemic measures. And at that time, patient was okay and he was pain-free. Then what happened? After finishing Agrestat, few hours after the end of his Agrestat dose, the patient developed sudden severe chest pain, which was not relieved by nitrates or even morphine. His ECG showed dynamic T-wave inversion. However, there was some ST elevation also in the lateral leads. So we suspected that the patient is having acute stent thrombosis. He was shifted for cath lab urgently, which confirmed the presence of stent thrombosis. PCI was done with thrombectomy, balloon angioplasty, and again the patient was started on Agrestat for 48 hours. Then what happened also again? After the end of Agrestat, again the patient had sudden severe chest pain. He had some dynamic T-wave inversion chest lead, this time without ST elevation. And I want to emphasize that the patient at this time was on Agrestat, was on aspirin, and Brilinta as well. And he got severe chest pain and he was shifted to cath lab. This is due to suspicion of stent thrombosis without ST elevation, but based on his severe chest pain and some T-wave changes in the chest leads. In cath lab, this confirmed also that there was stent thrombosis. They did thrombus aspiration, balloon angioplasty, and again the patient was started on Agrestat. This is the third time that the patient receives Agrestat. At that time, we thought that this patient, there is something abnormal. He is getting stent thrombosis while on dual antiplatelet and while on Agrestat. Immediately after stopping Agrestat, maybe he has some hypercoagulable state. So we consulted our hematology colleagues. They came, they evaluated the patient, but there was no family history of hypercoagulable state, but they sent some tests which finally came back negative. And they advised that we can start Clexane together with dual antiplatelet after the end of Agrestat infusion. So after Agrestat, Clexane was started and the patient was scheduled for coronary angio with OCT, which showed well-deployed stent in LAD, and the patient was pain-free on Agrestat this time. Then what happened? Again, patient had stent thrombosis few hours after the end of fourth dose of Agrestat. And while the patient on dual antiplatelet and full therapeutic dose of Clexane, so patients taking aspirin, Brilinta, agrastat and clexane, and he got stent thrombosis. For us, this was very unusual. The patient again had chest pain and and dynamic T wave changes, so shifted again to cath lab, diagnosed with stent thrombosis for the third time during one hospital stay. Intra-procedure agrastat was restarted, and we considered that this patient is having resistance to antiplatelet like Brilinta, so it was shifted to prasugrel after the procedure. Also, we consulted our surgical colleagues to consider doing CABG, Lima to LAD, and bypass this stent in case this is recurrent again. Surgical team came and evaluated him and scheduled him for possible surgery if there is recurrence, because we did not know at that time what to do with this patient. Aspirin, Brilinta, and prasugrel, agrastat, clexane. There is very high risk of bleeding if we continue like this. And also, we don't know he will go on and develop stent thrombosis again or not. So again, he had stent thrombosis during the night shift. It was a nightmare. Patient had again chest pain, dynamic T wave changes, aspirin, prasugrel, agrastat, clexane, everything was there. So again, patient was shifted to cath lab, thrombus aspiration, balloon angioplasty, OCT was done, stent well deployed. Then after that, patient became pain-free on agrastat, clexane, aspirin, and prasugrel. So next morning, surgical team came and took the patient to the operating theater. Actually, it was a very tough decision, and actually they did very well with him, despite the high bleeding risk on this medication. Finally, patient had Lima to LAD, and he was doing well, discharged out of hospital, and came later on for follow-up. But the thing here that the patient, when he initially came to hospital, his ejection fraction was 50 to 55. But after this recurrent stent thrombosis, ejection fraction dropped to 35. But later on, with follow-up after Lima to LAD, ejection fraction improved again. His labs were unremarkable for hypercoagulable state, and troponin, of course, had too much elevation. This patient also did 7 angiograms. So also, I think it is a record for one patient to do it during 3 or 4 days in hospital. So I'll just go quickly through stent thrombosis to see what is it. Stent thrombosis is a rare but devastating complication of PCI. And with the increasing number of procedures, we expect also that we have a bigger number of stent thrombosis cases. The incidence 0.5% to 1%. Mortality rates are reported from 25 to up to 40 or 50% of cases. Actually, I think stent thrombosis is much more worse than the original MI that the patient came with. The pain was more severe. He was having some runs of non-sustained VT, too much sweaty, did not improve with nitrates. Even antiplatelet and anticoagulation did not help him and did not prevent stent thrombosis. So I think it is a much more dangerous and lethal than myocardial infarction itself. 20% of patients with the first stent thrombosis experience recurrence. Here also, it is important. But I did not see, since that time, patient is having 4 times stent thrombosis. Maybe 1 time, 2 times, but 4 times I did not see before. That's why I thought this case is interesting to share with you. And usually within 2 years of the first event. So on the basis of onset of stent thrombosis, it is defined either acute, subacute, late, and very late. Acute, like our patient, in less than 24 hours of the index procedure. Subacute within 30 days. Late from 1 month to 1 year, and very late after 1 year. Both bare metal and drug-eluting stent thrombosis occur commonly in the acute or subacute time frame. Drug-eluting stents, however, have a higher risk of thrombosis in the late and very late period due to incomplete industrialization. So, in an attempt to standardize the definition of stent thrombosis, It was divided into either definite stent thrombosis, probable, and possible stent thrombosis. So what is definite stent thrombosis? It's an acute coronary syndrome with angiographic or autopsy evidence of thrombus or occlusion within or adjacent to a stent. It is not a necessity to have ST elevation, just ACS after an index procedure with proof that there is thrombus either by angio or by autopsy. What is probable stent thrombosis? Probable stent thrombosis is unexplained death within 30 days after stent implantation or acute MI involving the target vessel territory without angiographic confirmation. So the main difference is angiographic confirmation or autopsy. If the patient had angiography, this is definite. You can decide it is definite stent thrombosis. But if no angiography and the patient already died, then it was probable that he had stent thrombosis. Possible stent thrombosis also is unexplained death occurring more than 30 days after the index procedure. So between probable and possible is the time. Within 30 days, it's more probable. More than 30 days, it is possible. So what are the factors influencing the risk of stent thrombosis? We have patient factor, we have stent factors, we have lesion factors, and we have medication. So what are the patient factors? Premature discontinuation or cessation of dual antiplatelet therapy. So we emphasize on patient many times that antiplatelets equals the stent patency. Once patient stopped antiplatelet, either the first antiplatelet like aspirin or the second like Plavix or Brilinta, he is at a very high risk of stent thrombosis, especially acute stent thrombosis. The second most common is smoking. If patient continued to smoke after BCI, he is highly likely that he will have stent thrombosis. And actually, when a patient drops to ER with acute chest pain after a recent coronary angiography, the main thing that we ask the patient in emergency department, did you take the aspirin and Plavix on daily basis, not skipping even one day? If he said yes, then it is good. Second thing, do you still smoke or you have quitted smoking? If he said yes, this is not good. If he is already taking antiplatelet, he is not smoking, then the chance that he will have acute stent thrombosis is less than other scenarios. Diabetes also, of course, it is a vascular disease. Acute coronary syndrome on presentation also is a factor that encourages the development of stent thrombosis because the body itself is prepared to form thrombosis over the natural artery. So once you put a foreign body, there is a high risk that this foreign body will attract more platelets and more coagulation. Thrombocytosis, of course, if you have more platelets, you will have more thrombosis anywhere, and especially if you put a stent, platelets can aggregate around this stent. Chronic kidney disease, of course, also chronic kidney disease, the most common cause of this in chronic kidney disease is cardiac. So renal patients also suffer too much complication from the cardiovascular system. High post-treatment platelet reactivity, this is also like reaction from the body, like you give platelets, the body also will try to make more coagulation. Cytochrome B219 polymorphism, this is like genetic factors. So lesion-based factors, diffuse coronary artery disease with long stented segments. So the longer the stent, the more chance that it can be occluded. Small vessel disease also, because the caliber also will make it more likely that it will be occluded. Bifurcation lesion, thrombus containing lesion, this is very obvious. Significant inflow, outflow lesions, proximal or distal to the stented segment. What are the stent-related factors? Poor stent expansion, this is the most common cause. Edge dissection limiting inflow or outflow. Delayed or absence of endothelialization of stent struts. Thicker stent struts. Hypersensitivity or inflammatory or thrombotic reaction to certain DES polymers. So the medication covering the drug-eluting stent, some people will have some reaction to this medication, which will cause, paradoxically, that this stent will be occluded. strut fracture, late malabsorption, aneurysm formation, development of new atherosclerosis within the stent with plaque rupture, because if atherosclerosis only, this is restenosis more than stent thrombus. But if this atherosclerosis rupture, it will cause stent thrombus. So what are the strategies that we use to minimize the occurrence of stent thrombosis? First, patient selection. So screening for likely adherence to prescribed medication regimen, including ability to afford debt. So before considering drug-eluting stent, we have to make sure patient can get dual antiplatelet, and also the compliance. If the patient is not planning to buy it or will not be compliant, then we can see it in a different way. If the patient will need CABG, then CABG will be a better option. If the patient will get bare metal stent, it will be a better option if the patient is not planning to go for a long time on that. Careful screening for bleeding risk also, or ability to tolerate that. Because if the patient is having also some bleeding problem, then once you give that, he will bleed from somewhere like GI or so. Then maybe he will go to some surgeon or GB or so. He will decide to stop dual antiplatelet. So also prescribing a proton pump inhibitor is a very good option, especially in the acute phase, to help cover all the possibilities and prevent GI bleeding, which is the most common cause of stopping that. Sometimes the patient himself, he will tell, I started having some gum bleeding, some rectal bleeding or so, so I stopped that. Then again, he will get into stent thrombus. Also confirmation of upcoming surgical procedures in the recent future. Because if the patient is planning also surgery, if the coronary angiography is elective, then better that he will have surgery first, then he will have coronary angio after surgery, so he will take TAPT without interruption. But in case of emergency, there is nothing much that can be done in this situation. So stent selection and deployment. Consider use of stents with proven low stent thrombosis, newer generation, appropriate vessel sizing, high pressure stent deployment, and post dilatation, ensuring absence of edge dissection, ensuring adequate inflow and outflow, avoid the use of two stents in bifurcation region, of course, if possible. Pre and post procedure care. Also, the use of more potent oral antiplatelet, like escalation of therapy from Plavix to ticagrelor or to prasugrel, if indicated, such as our scenario. Sometimes it will just solve the problem if you change it the second antiplatelet. And of course, aspirin is indicated in all cases. Also, patient education and the clinical follow-up, emphasizing the importance of adherence to prescribed dual antiplatelet. So the first follow-up after coronary angio, the main thing is to check if the patient is having some hematoma at the site of coronary angio, and of course, the compliance to dual antiplatelet. Even if the patient knows and upon discharge, the discharging doctor informed him about the importance, again, the one who will follow him in OPD has to stress on this point, because it equals to his life. So usually we tell him, get this dual antiplatelet. Once you stop it, you may have a heart attack again. We should make it clear for him. Continuation of dual antiplatelet without interruption if possible, if dental, endoscopic, or surgical procedure is necessary. For most procedure, continuation of dual antiplatelet, and even in some patients, warfarin with therapeutic INR is possible, except for neuro and vascular surgeries. So as long as the procedure is low bleeding or low risk procedure, most patients should not stop aspirin and second antiplatelet or dual antiplatelet. And the best option is to consult cardiology if you have doubt whether to stop it or not. So don't stop it, just ask the opinion of cardiologist. He will tell you whether it is safe or not, and whether it is indicated or not. So what is the treatment of stent thrombosis? Stent thrombosis may be treated with emergent thrombectomy, either aspiration or mechanical, or with balloon angioplasty alone, often in conjunction with administration of more potent antiplatelet regimen, including glycoprotein inhibitors like aggrastat or integralin. The placement of additional stents should usually be avoided unless a mechanical reason for the initial thrombotic event is ascertained, like edge dissection or residual untreated lesions. The use of adjunctive imaging, such as IVAS or OCT, will often reveal a possible cause of stent thrombosis, such as stent under-expansion or malapposition, residual dissection, or significant inflow-outflow stenosis, and is thus recommending following thrombectomy. In the absence of mechanical cause, hematological evaluation should be performed to exclude hypercoagulable state, including resistance to aspirin or clopidogrel or thrombocytosis. Maintenance of antiplatelet therapy is typically escalated in cases of stent thrombosis. So clopidogrel is switched to prasugrel or ticagrelor. And here also we remind our colleagues that once switching from a stronger antiplatelet to a weaker antiplatelet, you have to wait for 24 hours and give loading with the weaker antiplatelet. But in our situation, if you go from a weaker antiplatelet to stronger antiplatelet, you don't have to wait. You just give the loading of the new drug and continue immediately. You don't have to wait. So from stronger to weaker, you have to wait. From weaker to stronger, you don't have to wait. In both cases, you have to give loading for the new drug to maintain blood level before the maintenance dose. Finally, surgery with CABG to bypass the area of recurrent stent thrombosis may be considered in individual cases based on expert opinion, as it was seen in our patient. So take-home messages. Understanding stent thrombosis, it is a rare but serious complication of PCI, equal in both drug-eluting and bare metal stent for early and late, frequently in first-generation drug-eluting stent. High index of suspicion is very important. Even if the patient doesn't have ST elevation, it doesn't mean that he doesn't have stent thrombosis. So like you diagnose any ACS, you diagnose stent thrombosis, but the circumstances will guide you. Either this is the regular ACS of native artery, or if the patient had recent procedure, it can be stent thrombosis. So you address also patient lesion and stent factors. Prevention, good technical results and effective dual antiplatelet therapy are critical in minimizing the risk of stent thrombosis. A significant amount of research has been done to explain high on treatment platelet reactivity for clopidogrel, especially cytochrome B C129. However, little information regarding ticagrelor resistance, with very few case reports worldwide. And currently, there is no guidelines for prevention of recurrent stent thrombosis other than dual antiplatelet, stopping smoking, and the routine care of post-coronary angiography. And finally, we need to emphasize that we learn from our patient every day. There is something new that we can learn. And we will gather all the experiences from our colleagues to help our patients. And thank you so much.
It was an interesting talk on stent thrombosis.
Thank you so much.
So I would like to know, what is the incidence of stent thrombosis that is there in your country?
Actually, it is not that common.
Yeah.
The rate is almost the same or maybe less than these figures, 0.5 or 1 per 100 procedure. It is less than this number actually, but because the cases that we faced here, it was devastating actually, and the number of attacks that the patient had it was like brand new for us to see 4 times of stent thrombosis in acute hospital setting. This was the biggest number I have ever seen. But maybe during 2 or 3 years, maybe like 4 or 5 cases, but none of them had more than one attack.
Okay, okay.
And usually there will be also some like antiplatelet discontinuation, smoking, some other risk factor. Patient will go home and come back with stent thrombosis or some restenosis. But in hospital, I think the incidence is much more less than out of hospital.
Oh. That's a high incidence actually. Okay, so do we have any questions from the audience?
Islam, good evening. Dr. Rajesh here.
Good evening, Dr. Rajesh. How are you?
Fine. See, now my question
Thank
is,
you.
what is the, during this stent thrombosis, we will be having the aspiration of thrombus, right?
Yes.
So by the color of the thrombus, can we identify the different types of thrombus?
Yeah, sometimes it is you can identify, sometimes you cannot, because also the scenario itself is strange. If you have patient with on dual antiplatelet, on agrestat and on Clexane as well, then you will have stent thrombosis. This is very strange. Almost you will not have fibrin, you will have some platelets only, but sometimes it is difficult to decide the etiology. Actually, this patient, after also hematology screen, came back, it was negative. So we did not know what is the reason. We solved the problem, but we did not know the exact cause that this patient had this frequent recurrence of thrombosis. First, it was suspected that he's having some resistance to Plavix, resistance to clopidogrel, to Brilinta, but it turned out to be that it was not the antiplatelet. There is something that we could not identify 100%.
Yes, I agree. Thank you very much for wonderful talk. It was extensive coverage of almost all the points in stent thrombosis. We enjoyed. Thank you.
Thank you so much, and thank you for joining during your leave. I will be having a small talk at the end after Dr. Raul, and I am waiting also for his session. He will cover also a very interesting topic regarding stent endarterectomy.
Yeah, please.
Thank you, Dr. Islam. That was a really interesting topic.
Thank you so much.
Something which we don't read much as clinical cardiologists. Thanks a lot. I'd be inviting the next speaker, Dr. Rahul Rao. He's a cardiothoracic surgeon from Narayan Hridayalaya at Bangalore. He would be talking about the surgical management of it, of stent thrombosis. He'll be speaking about stent endarterectomy. Over to you, Dr. Rahul.
Hi, Dr. Sheetal. Good evening, everybody. And hello to everybody from other parts of the world who are joining in. I hope all of you are safe during this pandemic period and taking precautions and being careful. I think I'll share my screen now to so that I can show you the PPT. What I will be talking is a little at the other end of the spectrum of coronary stenting, because what Dr. Islam was talking about was the problems they've had in the acute setting. And fortunately and thankfully, I have not come across a situation where we had to do an emergency surgery on a patient with such an acute blocked stent. And frankly speaking, a patient on so much of antiplatelets and blood thinners would be an absolute nightmare for a surgeon, because of the potential, not a potential, which is a very, very high risk of bleeding intra and even during the post-op period. So it's very great that that patient did well and went home after a graft on the LAD. Right. So I think, yeah. So can you see my screen now?
Yes, we
Yeah,
can see.
it is.
Yeah.
Yeah. So my talk will be about the surgeon's perspective. I'm a practicing cardiac surgeon in here in Bangalore, India. So for us, this is the we all know this normal coronary anatomy, wherein you have the left coronary and the right coronary, the left coronary branching into the circumflex and the LAD, and then the divisions of the LAD and the circumflex. The LAD becomes proximal, mid, and distal, based upon the diagonals and the septal arteries. So, for a surgeon, as for a perspective from a cardiac surgeon's perspective, the most important vessel for us is the left anterior descending artery most of the time. That is why if you go back to our basic medicine of anatomy and physiology, it's called as the widowmaker of the heart. So for all of our surgical revascularization procedures, the LAD is the most important artery for us. And the time tested thing is that whenever we graft the LAD with the left internal memory artery, that is the gold standard, and that gives the long-term benefit for the patient once post-op. Right. So this is a happy surgeon when the coronary arteries at the spot is clean, especially when the LAD is clean. Right. This is a small image where we can see how the CABG is done. You have this left intermammary artery grafted to the LAD, and we have a reverse segment of the saphenous vein, which is harvested from the leg or the thigh, and it is grafted to the right coronary artery, and the proximal anastomosis is on the ascending aorta. Similarly, we have one more image where we have three grafts here. This looks like more like a pedicled mammary on the LAD, and the vein graft on the obtuse marginal, and the vein graft on the right coronary. So moral story for us in cardiac surgery: good vessels, good ventricular function, good outcome. Bad vessels, good ventricular function, fair outcome. We can make it good by doing a little more complex procedure like an endarterectomy. Bad vessels and a bad ventricle have a poor outcome, and most of them are not considered for surgery. So coming to coronary artery intervention, which Dr. Eslam has already spoken about, really been a game changer, made a huge difference in saving lives, especially in the setting of acute coronary events. And that is why it's so commonplace. We find cath labs everywhere, and so should it be, so that a lot of people, instead of getting just medical therapy, should undergo intervention, so that not only lives are saved, also the heart muscle is saved. So this question, stent thrombosis, what next? Nicely dealt with by Dr. Eslam. I will be talking about the more or less the late and very late stent thrombosis and what we do as surgeons when the patient comes for surgery. So as a cardiac surgeon, a post-stent vessel is something we worry about. Reason: because there are a lot of changes what we see on the table when we open the vessel. The vessel wall is thickened, the vessel lumen is narrowed, and the distal runoff of the vessel is quite poor, which is a very bad sign for any vascular surgeon, because if you don't have a good distal runoff for your graft, it can be anywhere in your body, coronary or peripheral vascular, anywhere. I mean, I don't do peripheral, but I'm just saying as a general vascular principle, then the graft doesn't flow that well. So what we try to do in these situations, the solution is we try to do an endarterectomy, wherein we remove the plaque, and in case there is a stent, we remove the stent so that the lumen size increases, then augment the arterial wall with a vein patch or an artery patch, and then graft it. Okay. So what is the indication? The most common indication for a coronary endarterectomy is mostly and usually in the left anterior descending artery territory. The reason being, like I said, that's the most important artery, and especially in long-term patients who come on long-term follow-up, there is adequate collateralization so that when we actually have a good graft on the LAD, it more or less perfuses the rest of the myocardium from for the other territories as well. So especially when there is a long segment stenosis at the stent implantation with diffuse distal arteriosclerosis, most important for us is the septal perforators, which are very, very important. And when they get blocked, either because of a stent or because of intrinsic atherosclerotic disease, that becomes important for us. And removing the plaque and doing an endarterectomy may relieve the ischemia. And also in some cases of where you cannot do a sequential bypass graft. What are the indicators of a good surgical outcome? If you remember my previous slide where I said good ventricle, good vessel, good outcome. So whenever we think of an endarterectomy for a patient, a basic ECG will be a very helpful investigation for us to understand whether the patient will benefit from that procedure or may not. So a good R-wave progression in the anterior leads, which indicates the anterior wall of the myocardium being preserved, is a very good indicator that the procedure will be very helpful for the patient. And also in the echo, if you have a preserved muscle thickness, a normal ventricle also indicates that the most likely the procedure is going to be very, very beneficial. We do advanced imaging in many of the cases, like a cardiac MRI or a thallium scan, basically a perfusion scan, to look for viability of the myocardium, so that we know preoperatively that the patient is going to benefit or not. So the surgical approach is basically cardiac surgery can be midline stenotomy or thoracotomy. A lot of talk and a lot of fame for the minimally invasive bypass from robotics to endoscopic and all that. But in our setting of a stent endarterectomy, I think we have still not reached that level of skill. So most of the cases we'll be doing a midline stenotomy, right? The next question is the most common question what all of us have is it an off-pump procedure or an on-pump procedure? Basically meaning to say whether we put the patient on a cardiopulmonary bypass machine or we just do it with the beating heart. Yeah, this is a small video. I think I have repeated this video previously. Basically, I'm doing a stenotomy here and my colleagues are harvesting the veins from the leg. The next question is the choice of conduits. Like our previous case, which Dr. Eslam was talking about, I think the surgeons got away with the just a lima to LED, and I don't think they had to do an endarterectomy because probably the distal vessel was good. There are other choice of conduits, like you can use the right internal mammary artery. So many times if the mammaries are not good and not pulsatile, we might need to use the saphenous veins for whatever reason, and also a radial artery can be used. This is a small image of the cardiopulmonary bypass circuit, wherein we put an aortic cannula into the cannula in the aorta for the arterial return. Venous cannula into the right atrial appendage. It goes through the reservoir, the pump, oxygenates, filtered, and it is given back to the patient. This is one more image, again showing you the left anterior descending artery. In this case, it is quite clean. So this is a good vessel to graft. Right. Now comes to the difficult part. So if you see here, this is an angiogram still image, wherein the left anterior descending artery has been stented for quite a long segment, and the first septal is blocked and the distal vessel is quite small. So in this situation, we don't really have an option but to go in and remove the stent and then augment the LAD with the vein patch and then graft it. Right. So this is what's happening. In this case, we are on bypass. We have cross-clamped the aorta. This is RA cannula and the aortic cannula in. And then here is the LAD. We're removing the stent. And the stent is out. We have the LAD here, which is bare out. And we have the septals, which you can see here. And next, this is the specimen which has come out with the diagonals and the septals. So now we have augmented this with the vein patch. These are images which I got from this original article from Turkey on surgical revascularization of the left anterior descending artery with which had stent blockages. This is one more article. They had about 3 cases, and both these articles describe on-pump grafting, which we also practice and follow. So again, you have this long segment of the LAD which is blocked with a stent, and then they have opened the LAD. The stent is coming out here, and you have the septal perforator. This is one of the most important vessels for me in the LAD. Once we clear out the septal branch, and when we graft it, we know that the heart muscle is going to contract well because of the adequate perfusion through the septal branch. So this is the specimen which is out. You can see the stent, the scaffold of the stent here. This is an interesting article which I went through, and this is from Sakakibara Heart Institute, Tokyo. As you know, Sakakibara classification for the ruptured sinus of Valsalva is also from the same name. They have described an off-pump technique, which for now we are not following. And I would like to go probably and see them do it and learn something from them. So basically, they do it like any of what we do for the off-pump coronary artery bypass, and they do the whole procedure off-pump, and they use the left internal mammary as a long patch and graft the LAD after they remove the stent. Right. So after this surgical tidbits are just common misconceptions about patients who come for surgery after they undergo PTCA, as in either in an acute setting, or sometimes even if they come after a long time on follow-up, either because of the stent getting blocked or some new disease, multiple diseases in the other coronary artery territories. So the most common questions what we get is, when you do surgery, are you going to remove the stent? Or if the stent is not removed, the question the patients or the relatives will ask is, why wasn't the stent removed? So I will just show you a few angiograms just to show you that where we do not remove the stent when it is not required. So in this case, if you see, this patient came to us for a coronary artery bypass. This is the right chute where there is diffuse vessel disease in the mid-right, and the branches are quite small. Then next we go to the, this is again another right chute. We go to the next chute where this is the spider view of the LAD and the circumflex. You can see this, yeah, I'm showing it here. See this long segment stent in the circumflex. Now, in this case, the circumflex stent is patent. So the policy is, when don't trouble until trouble troubles you. So let it be. So what we just need to do is graft the obtuse marginal and the LAD. And in this case, I think we had 2 grafts on the LAD and graft on the OM. So we did not touch the circumflex stent at all. Right. One more angiogram. So in this case, if you see, this patient came to us for an aortic valve replacement and a coronary artery bypass. So basically, he needed, if you can see here, he needed an obtuse marginal graft and also a left anterior descending artery graft. He has a right stent, which will come up in the subsequent views. I think you can see the opaque stent in this this part. Can you see that here? Yeah, that is the stent, right? So the right coronary was stented in this case, I think about 10 years back. And if you see here, the stent is blocked, but the stent, even though it is blocked, there is good collateral retrograde flow from the left system, right? And also the distal vessel is quite bad. So now if we graft the left-sided systems, the blood flow is going to get restored. And we really couldn't do much, I think, in this case on the right side, because the vessel wall is quite bad. And the patient needed an aortic valve replacement for which we had to go on pump. So the decision was not decided not to graft the right system. I also have a few intra images of this case, because we actually, when we opened the aorta here, if you can see here, we could see the right coronary artery jutting out, stent jutting out of the right coronary ostium. We had to open the aorta because we had to do the aortic valve replacement. So this stent part was jutting out. So even though initially we were not planning to remove the stent, a small part of the stent had to be chopped off so that it doesn't come into our surgical field. So this is the RCA stent piece which we cut it out. Now, okay, we are talking everything happy, but there are problems and complications which we anticipate and we have come across in our day-to-day surgical practice. General issues like for any cardiac surgery in the post-operative period, we can have bleeding, prolonged ventilation, ICU stay, need for an intra-aortic balloon pump. A lot of patients go into low cardiac output, especially when we do cases on cardiopulmonary bypass. One thing which I need to mention is that most of the cases, especially in our setting, in the Indian setting, or probably when we do a patient on do a surgery on cardiopulmonary bypass for a coronary, especially when the vessels are bad, an intra-aortic balloon pump becomes a necessity and is very, very helpful for us to tide over the post-op low cardiac output which the patient goes into. So if you happen to come across a patient who's been on an IABP on post-cardiac surgery, you may understand that his vessels would have been quite bad. So this is not really something which you need to be worried about. And a couple of days of balloon assistance and the patient actually does well. And mechanical assist is always preferable to a chemical assist, where when we pump in so many inotropes, the IABP really helps in cutting down the necessity to use a lot of inotropes. Right. In our experience in the past, this is my 2 years data, which we have had about 500 CABGs all in all, and about 23 LAD endarterectomies. We had one additional RC endarterectomy, I think. I forgot to mention it in my slide. Among them, 8 were LAD stent endarterectomies, and in our institute, I have not come across any other vessel endarterectomy. I happened to read an article on RC endarterectomy, but I have not personally done or seen it. So all of them were shifted with moderate inotropes and elective IABP, which is a usual protocol for us for most of the patients who undergo endarterectomy. One of them died in the post-op period due to low cardiac output. The reason was this patient was on the second line, what I described: bad ventricle, bad vessels, and post-op, even with IABP and supports, she didn't do well. She was there in our ICU for a long time, and then sadly she passed away. The other patient who had who died was because of a post-op COVID pneumonia. This was just when the COVID, was peaking in our city at that time, and unfortunately, I died because of that. So thank you so much for letting me talk. I'm open to questions.
Thank you very much, Dr. Rahul. It was excellent presentation, and you have covered almost all the scenarios. So again, my question to you as a surgeon, the same question which I asked to Dr. Eslam. Do you think the color of the thrombus, I mean, when there's a stent thrombus, or you must have opened the coronary arteries multiple times, according to the color of the thrombus, can you say something regarding that?
Not really, because I have not come across acute thrombus situation. And most of our patients which we operate have been, in the sense.
What we know is there are 2 types of thrombus we can come across during acute stent thrombosis. It can be white and it can be red also. If it is white, it is the total ischemic time will be, very, very less. As the ischemic time increases, the red cells infiltration will be more, and it becomes red. And the 30-day mortality as well as other adverse cardiac events will be less with the white thrombus. And if it is red, the mortality is almost double or triple. At the same time, the major adverse cardiac events are also used to be much, much higher compared to the white thrombus. That is what we know from the different types of thrombus.
Yes, I agree. But like I said, I have no experience operating on a patient with an acute stent thrombus, frankly speaking.
Okay.
Yeah, so if somebody's had, I think if they could share, it would be nice.
Yeah. Any more questions, Dr. Sheetal?
No, I think that was an interesting addition, Dr. Rajesh, you made. When I was wondering the first time you asked the question, what was the answer? Thank you for explaining that. And Dr. Rahul, thank you so much. It was an interesting topic. And you really made some points really very clear. Thank you for that.
Dr. Eslam wanted to present something by the end of this talk.
Yes. So thank you once again, Dr. Rahul, for joining us. We hope to see you again. Thank you.
Thank you.
And I welcome Dr. Eslam Rashid for another topic. It's a topic on emergency cardiology, how to approach. It will be a compilation of general tips and advices. Over to you, Dr. Eslam.
Thank you so much. And thank you, Dr. Rahul, for this excellent presentation, and also the techniques of removing stent. Actually, for me, it is brand new to know that this is possible, that you again can take back the stents. Okay, the next session will be for most of us, will be a basic knowledge rather than something new. But the target for this talk, is our junior colleagues and also our ER colleagues, emergency physician colleagues. So I think it will be helpful. As I said before, it will be no-brainer for most of us, but I think we need to emphasize some concepts, especially to our young colleagues. There is too much knowledge in textbooks and in guidelines, but if you made it simple, then we can follow during busy on calls and in the emergency department. So these tips, I can call it how to save your patient's life. And if you can do so for one patient, you can do it for 1,000 patients again. So everything should be made as simple as possible, but not simpler. Okay, so I'm trying to just present it in a simple way so that everybody can recall it and take an action based on this. As I said, it is not a guidelines and it is not a textbook presentation, but it's a different way that you can memorize and summarize what you are going to see in your practice as a junior cardiologist. So here, these are the ABCs. When you get a call from ER, you just get prepared for these ABCs. What is there? Arrhythmia for A, B for blood pressure, either high or low, C for chest pain, D for dyspnea, E for edema, F for faint or syncope, G is for general, and H for hemodynamic instability. So if you thought here around arrhythmia, the most common big mistake that we face in arrhythmia from some of our junior colleagues or some emergency physician, that when they think that this patient is having arrhythmia, they rush for ECG. Actually, the first step is to check the vitals, not the ECG, because if your patient is unstable, the treatment will be based on monitor, not ECG. You don't have time to do ECG and get an opinion or so. So first step, once you suspect this patient is having arrhythmia, connect to monitor and check vitals before doing an ECG. Then you can manage also the risk and the treatment based on monitor. So 12 leads ECG will make no difference in a patient with ventricular tachycardia. If the patient is having VT, you can diagnose with one lead only. No need to do 12 leads, it will take time. But give him DC in a part of second, he will be back to sinus rhythm, or you can proceed further for the SLS. So this is for the arrhythmia. Either it will be tachycardia or bradycardia. Patient will either be stable or unstable. Based on what? Based on vital signs. So for some good reason, they call it vital signs, signs of life. Once it is there, then the patient is stable. Once the vital signs are disturbed or absent, so the patient is sick or dead. So based on vital sign, you will proceed. Either the patient stable, you can get your time, do ECG, consult cardiologist. Even some cardiologists will consult EB colleagues for some difficult reason. But everybody will agree that in an unstable patient, there is few rhythms that you need to know. Based on one lead only, you can diagnose and also you can treat, and all are given in the ACLS. Second is blood pressure. So blood pressure also, you will find textbooks to teach you how to treat blood pressure, which medication to choose, and so on. But my aim here is to identify who will get harm from this blood pressure. Blood pressure either too much high or too much low. So for too much high blood pressure, you can call it crisis, and too much low blood pressure, you can call it shock. But you have also something else here. The number itself is not a guide. So you need number plus clinical. So for hypertension, severe hypertension, blood pressure should be 220/110 or any of these. For shock, blood pressure below 100/60 plus symptoms, because some people, especially those with anemia and some females, will have low blood pressure all the time, but without symptoms. So if you have symptoms of hypoperfusion plus number, then you can diagnose shock. We'll go also through shock in some detail. Chest pain, also, there are more than 15 causes of chest pain, but your duty in ER is to just check the lethal causes excluded, then the patient may go and follow an OBD and may do some workup, further workup to diagnose what is the cause of chest pain. In some cases, it will be a very rare cause, it will be a syndrome, it will be only psychogenic, but at least you exclude the top 5 killing causes in the ER. Also for dyspnea, dyspnea is either acute or chronic. I also want to emphasize here that for each of these figures, you will have key to manage the patient. So if you have arrhythmia, the key here is not the duration, not the rhythm itself, but the stability of the patient. In blood pressure, you will have also a key. The key here is not the number, it is the effect of this number. So if you have 220/110 without organ damage, you have time to deal. If there is target organ damage, this will guide you to aggressively treat this blood pressure. Same also for shock. If you have a patient with blood pressure 90/60 or 100/60 without symptom, patient is going, walking, and have no symptoms, maybe you'll do just nothing, especially for those myopathic patient with ejection fraction 15 or 20%. Almost all the times you will have low blood pressure, and you don't need to do anything for this blood pressure, just continue with anti-failure medication. For chest pain, as we said, the key here is to exclude life-threatening causes. For dyspnea, the key here is to decide it is acute or chronic, because also many patients, obese patients, will have dyspnea throughout most of their lives until they lose weight. Some smoker also and COPD will have dyspnea for a long time, some anemic patient will have dyspnea for a long time. So the main aim in emergency department is to decide whether it is acute or chronic, because acute dyspnea is very lethal. If you did not diagnose and target the cause of this dyspnea and treat it, almost the patient will either die or deteriorate very rapidly, because no one can survive without oxygen for a long time. So acute dyspnea is usually more severe to bring the patient to ER, and the causes also are very eminent and very dangerous. Edema also, you will have pulmonary edema and peripheral edema. Peripheral edema is organ failure. Pulmonary edema is heart failure. Pulmonary edema also, you have cardiogenic and non-cardiogenic, and we will go through this. So peripheral edema is not the big deal. Still, you have to do some workup to diagnose the cause, but in some cases, you will find only some venous valves that is absent causing peripheral edema. However, in pulmonary edema, if it is present, this is very dangerous, and mostly you will admit the patient for treatment, and also you confirm your diagnosis, especially if it is the first presentation for a previously healthy patient. Also, F for faint or syncope. So syncope also is a very common presentation, and the trick here is to decide whether it is cardiac or not, because according to statistics, 50% of cardiac syncopes may die within 1 year if not diagnosed and treated properly. So you just exclude cardiac syncope, then syncope mimics also that may look like syncope, but actually it is not syncope. Then everybody is happy. I also need to emphasize that some patient will get admitted to hospital maybe for 1 week, and no cause will be detected after extensive investigation. That's why your main aim in ER or during the acute hospital stay is not to diagnose the cause in syncope, rather than to exclude cardiac syncope or lethal causes also. Again, patient may present to cardiology with general presentation. And I mean by general is fever, anorexia, headache, malaise, or a combination of all. So the patient will come with fever, then you discover that he may have some cardiac problem based on ECG, based on chest X-ray, based on troponin, based on any of the above complaints. Some patient will come with pericarditis alone, some with myocarditis, some with endocarditis. Some will come with combination, myopericarditis or endocarditis in myocarditis and heart failure. And previously, everybody knows that rheumatic heart disease can present with pancreatitis, so he can present with any of these during the acute phase. H is for hemodynamic instability. So also, I need to emphasize that the first thing you do in emergency is to check for vitals. Some of the colleagues will, when they see a patient with chest pain or sick patient, they immediately rush for, we need to do X-ray, we need to do ECG, we need to do echo. Then the patient is already shocked. He has unrecorded blood pressure. So what is the benefit of coronary angio if the patient is already shocked, you did not resuscitate in the immediate period? This will have a very bad impact on the further management. If you find the patient shocked, you start with treatment of shock, then you shift him to cath lab. If you find the patient with STEMI, he is shocked also, you start management of shock, then you proceed. Patient with arrhythmia, unrecorded, you have to deal with the arrhythmia and treat shock also at the same time. So please check vitals in any acute patient to decide whether this patient needs immediate attention and he should be attended at all the times, or this patient stable, you can shift to regular ward also. Finally, remember, this is what I have learned from my seniors and the professors. Seeing patient is better than not seeing and giving just an advice or assurance, and writing also is better than not writing. So whenever you are asked to see a patient, I think it's a good option if it is a sick patient, you see and give your opinion, even if you think it is not a cardiac problem. And also writing the finding is very important, because sometimes you need to go back to what you wrote and check how was the patient at that time and compare he is improving or not improving. So in brief, we'll go through some advices in arrhythmia. Connect patient monitor to everyone with arrhythmia and have DC nearby while giving antiarrhythmic medication. Things can change in a part of a second. So if you saw one patient with SCVT is not known to be a malignant arrhythmia. However, maybe during giving adenosine or during giving digoxin or some beta blocker, some calcium channel blocker, the patient may crash. So what are you going to do at this point? In some people also, the rhythm may change from some atrial rhythm to VF, or the patient can have a systole during the treatment of SCVT, even this very benign rhythm. So always get ready with the DC. And actually this patient, if you have a resuscitation room or high dependence unit or intensive therapy unit, this patient should be in this place. If the patient is stable, get an ECG. If he is unstable, get the DC and get ready for intubation. Of course, some people will need intubation after you give sedation and DC, and especially if he's having VT, then mostly he will need some sedation. Maybe there is recurrence, some electrical storm will come, and that's all. Check vitals to know the patient stable or not. I remember one time during an on-call, one of the colleagues called me, please, I need you to see this patient. He's having some arrhythmia. I don't know, this is VT or this is SCVT with bundle or so. Then I asked the next question, is the patient stable or not? Because at that time I was busy with some sick patient. So what was the answer? He told me, I don't know, he's stable or not. You come and see and decide. Then I left everything and I went, I saw the patient. After finishing this consult, I told him how you cannot decide if he's stable or not. He said, I don't know. Give me something to differentiate he's stable or not. Then I thought in his question, for some of us, it is a no-brainer, but actually the key here is vitals. The patient is vitally stable, then he is stable, and if the vitals are disturbed, then the patient is unstable. And the vital signs are also not pulse, pressure, temperature, respiration alone. There is also fifth vital signs, which is blood sugar, there is pain, and there is conscious level. So all these 7 are the vital signs. Of course, we have to concentrate on the basic 4, pulse, pressure, temperature, respiration, but still we have to check if the patient has everything stable, but is in severe chest pain, then he is unstable. And usually this patient with severe chest pain will have tachycardia, will have hyper or hypotension. But in case he's on beta blocker, but he's having severe chest pain, heart rate is okay, still he has some sign of instability. Blood sugar also, if low, this is a sign of instability. And disturbed conscious level, if it is acute, it is a sign of instability. So again, emphasizing that the signs of instability, confusion, shock, SOB, chest pain, LOC. If the medication doesn't work, proceed with electricity devices. And I mean here either DC or the batches for transcutaneous pacing. So sometimes if you give a patient atropine, still brady, you try dopamine, still brady, you try adrenaline infusion, still brady, then you proceed with transcutaneous pacing, then temporary pacing, then permanent pacing if needed. Again, also for arrhythmia, if you given for VT, you given VT with pulse, you give amiodarone, you give xylocaine, you give magnesium sulfate, still there is VT, you give him DC shock. Always look for treatable causes like potassium, hypokalemia, magnesium, glucose also. I have seen cases with VT as a presentation for hypoglycemia. So after treating blood sugar, patient arrhythmia completely disappeared. And also, if you think it back, patient with hypoglycemia will die from either sympathetic overstimulation or brain damage after some time. So during this sympathetic, he will die also from VT. And this is the reason that we don't like to give very tight glycemic control for cardiac patients. Also, of course, MI, inferior MI with heart block or bradycardia, if you just open the RCA, the patient arrhythmia will resolve by its own. Non-sustained VT with anterior MI, also if you open the LAD, mostly the arrhythmia will go by itself. BE also sometimes. Sinus tachycardia is not the disease itself. Sinus tachycardia, it is the presentation of pulmonary embolism. Unexplained tachypnea and tachycardia are the surest signs that this patient is having BE. But I mean unexplained tachypnea and tachycardia, because if you have fever, you will have both tachypnea and tachycardia. Some patient will have pneumonia, he will come with SOB, he will come with tachycardia and fever. But here it is explained. But if there is some patient coming with sudden SOB, tachycardia, you don't see any visible causes, no anemia, there is no fever, there's no pneumonia, lungs are clear, mostly this patient is at risk of BE if it is not BE. Hypoxia drugs also. Don't leave that patient unattended at any point until stabilized. So this is also the reason that you have to check vitals when the patient drops to the ER. And again, after some time, if you are planning to shift to ward or to CCU or to lower dependency unit, then you check vitals again, because if there is significant change in vitals during short period, this is a red flag that this patient should not be left unattended and he should be in ICU or some higher dependency unit. If cardiac arrest develops, proceed with ACLS. So always I advise my colleagues, junior colleagues, to take ACLS course. And after some time, if you can take it again and renew your license, this is very good. Because once you know what to do at the arrest time, you will feel confident during the management of what is before arrest. Because before taking this ACLS course, for me, I was afraid what I'll do if my patient arrested or died or severely deteriorated while I am doing my management. You face sick patient, you start your management, then what is the next step? Either he will stabilize and improve, then everybody is happy, or he will deteriorate and develop sudden cardiac or respiratory arrest. What you will do? If you know what to do, then you will feel more comfortable in the management, even if he did not arrest. Again, blood pressure, we spoke about high or crisis, low or shock. So crisis either will be hypertensive emergency and hypertensive urgency. And usually during this step, I ask my friends, what is more emergent or what is more acute, emergency or urgency? And of course, emergency is more acute. That's why they call it emergency department, not the urgency department. So emergency is emergency. Urgency is a lesser degree. How you decide? You decide by target organ damage. If there is target organ damage with hypertension, this is an emergency. You have to lower blood pressure roughly. I will tell you, lower it around 25% in the first 6 hours. If no target organ damage, this is urgency. You can lower 25%, but in 24 hours, not 6 hours. And of course, if you want to lower the blood pressure significantly, you have to use IV medication. Patient should be in CCU for emergency and for urgency, patient can be managed on ward. You can start oral medication and the effect will be after some time. So make sure blood pressure cuff is appropriate size, because also many scenarios I have seen that a patient blood pressure cuff is either undersized or bigger size. It's a problem that if it is too tight, blood pressure will show too much high. Maybe you will give medication. After that time, patient will develop shock because it was already not elevated. You give too much medication for a wrong number. The same also applies for very loose cuff. I got consult before, some patient is in shock. Then I went, the patient is perfused, she is good. She doesn't look that she has shock. Then when you check blood pressure, the cuff looks too big. There is no number. There is good pulse, but the number is like 80/40. We change it to the Brewer cuff size, then how much it came, 120, 110. Okay, this is good. This is going with what we are seeing in the patient. So make sure your scale is good. Check symptoms or signs of hypoperfusion and peripheral pulses. Check also both sides, especially with chest pain, because the first priority is to rule out dissection if you find some unilateral loss or absent pulse. Treat hypotension first, diagnose the cause later. As we said, if the patient is in shock, you put a large bore cannula, you start IV fluid, bolus. Then, if not improving, you will proceed with support, no matter what is the cause, because you have how many causes for shock you have? Septic shock, hypovolemic shock, obstructive shock, cardiogenic shock, and the kinetic or anaphylaxis. So for septic shock, what is the treatment? You give fluids, inotropes, and antibiotic. Hypovolemic shock, also you give fluids until blood is ready. You correct the cause for hypovolemia. Obstructive shock is like BE and aortic dissection or tamponade. So what is the treatment also? You treat shock and stabilize the patient for the next step. Either you will go for CT pulmonary, either you will give thrombolysis, either you will go for surgery, but all of this will need the patient to be stable until he is shifted to the next step. So if you keep him in shock, the next step, he will have very poor prognosis. So once the patient is going to the procedure in a good blood pressure, good heart rate, then after the procedure, of course, he will be much more better. But if you went in a very bad condition, even to the cath lab, maybe he will not feel the radial pulse or femoral pulse. The patient will arrest on table. The stent will get occluded once patient blood pressure is unrecorded. So cardiogenic shock also, some people will tell how we'll give fluid to cardiogenic shock. Even cardiogenic shock itself is not a contraindication. So first you need to feel the circulation, then you start pumping. So if the patient doesn't have much volume in the circulation, even if the heart is pumping well, he will still be in shock. So some people, you don't know what is the optimal volume for them. You can start with fluid challenge. Then if the patient is still congested, blood pressure is not rising, saturation is coming down, then you start inotropic support. Kinetic shock is from anaphylaxis. You will give adrenaline, of course. You will give steroids, of course, antihistaminic, of course. But this will take time also to work. At this time, you start IV fluid while doing the other measures. Severe hypertension needs immediate treatment except in CVA. So usually we don't touch blood pressure in CVA to avoid further progress of the ischemia. Check for target organ damage to decide how aggressive you are going to treat blood pressure. If there is target organ damage, patient will definitely need ICU or CCU. And again, to remind you, for shock, as we said, once you are faced with patient with shock, there is a small bedside trick that you can apply. It will give you a clue why the patient is shocked. So septic shock with the S letter, the patient should be warm skin. So shock, unrecorded blood pressure, but skin is warm. This is actually very strange because other causes will have sympathetic stimulation to counteract shock. The patient will be cold. And also anaphylactic shock because of severe vasodilatation, patient's skin will be warm. So you can go to at the bedside, touch the patient's legs or hands. If it is warm, this will give you clues. This is either anaphylaxis or sepsis. If it is cold, and usually patient is sweaty and pale, this may be hypovolemic, may be obstructive, may be cardiac. You cannot decide until you go for further testing and start your treatment. You can do echo also in this patient. This will be very helpful, and it is one of the indication for emergency echo or urgent echo. Patient had sudden deterioration of blood pressure or heart rate or sudden hemodynamic instability. Chest pain. There is also a very common question that ER doctors ask us and our junior colleagues, how you decide this patient is having STEMI or not. Of course, ECG is very important. And of course, troponin is very important. But the most important is chest pain, because even STEMI cases can present with non-specific changes. They said around 50% of patients will present with non-specific changes if the ECG is done very early. And also, of course, you will not wait for the results of troponin to decide whether it is a STEMI or not, because at least it will take 1 or 2 hours. So troponin is out of the game in acute STEMI. Even if the patient presented very early to ER, and even if you waited for the result, it can become normal also. So you will not depend on troponin. So let's get troponin out of the game in STEMI. In non-STEMI or unstable angina, it is important to differentiate between non-STEMI and unstable angina. But in STEMI cases, troponin does not exist. It may exist if the patient came asymptomatic and you want to see if this ECG changes evolved with MI or no. There is Q waves and this thing. So you find troponin is a very big number. Maybe he infarcted 1 or 2 days like this. But if the patient dropped with a new chest pain, acute chest pain, troponin will not be helpful. ECG, as we said, maybe there will be non-specific changes, but the patient is having typical severe chest pain. What we will do, we will keep him connected to the ECG and we will do serial ECG. So sometimes we'll get consult for severe chest pain in ER. ECG doesn't look bad, but the patient himself looks bad. He has a bunch of risk factors. He is sweaty. He has some sympathetic. And previously also, there was one tip given to me by our ER colleagues. He said, autonomic system doesn't lie, it's MI. So once the patient is having chest pain plus autonomic, like sweating, nausea, vomiting, this is very serious. Even if ECG doesn't show anything initially, you have to keep doing serial maybe every 5 minutes, every 10 minutes, according, and check until the patient pain resolves or you see any changes that you can shift to cath lab. And I think this is also reflected in the guidelines that they wrote STEMI equivalent for the cases that there is no ST elevation fulfilling criteria for STEMI, but still there is high risk ECG finding and high risk coronary angio finding, like Welling syndrome. You have De Winter T waves, you have ST elevation in AVR with universal ST depression, like this. You can find negative troponin in fresh MI and the persistent ST elevation in old MI, so be careful. So also, troponin can have fallacies, and the ECG also, you can have other causes of ST elevation, like 5 or 6 causes of ST elevation. One of them is old MI and LV aneurysm. So if you made your decision based on ECG only, you will get fallacies. If you made it based on troponin only, you'll get fallacies. But almost if you look at the chest pain, it will guide you in the right pathway. Quality also and the severity of pain is even more important than this troponin and ECG. Always rule out acute aortic dissection before giving aspirin and heparin. Sudden chest pain plus neurological deficit is aortic dissection until proven otherwise. Also, sudden chest pain with absent pulse at any site is aortic dissection until proved otherwise. If pulmonary embolism is highly suspected, always give heparin before doing CT pulmonary angio is arranged. Because what you will get if the patient arrested during the procedure, already you diagnosed or you suspected, highly suspected pulmonary embolism, this is good, but the patient died. So the outcome also still 0. But if you started treatment, even if you cannot do CT pulmonary angio, still high suspicious, you have other modalities. You have bedside echo, you have VQ scan, and etc. And you can, and again, as we said, bedside echo is very helpful in acute chest pain and acute SOB. Sometimes you will find some young patient, like 30 years, with no risk factors, is coming with very severe chest pain. ECG also is not conclusive. There is no reciprocal changes. There is some ST changes. You cannot tell this is STEMI, and you cannot shift to cath lab. But once you use bedside echo, you either will find some wall motion abnormalities that equals the ECG, and you can make your decision based on this. You can find severely dilated right side and signs of pulmonary embolism. You can see also a dissection flap in the ascending aorta, and you can see pericardial effusion or some tamponade or so on. And again, I want also to emphasize this, that time for lytics or case in MI only counts after you confirm the diagnosis, not before. This is also important because some of our junior colleagues will tell, okay, let's go to cath lab. First, we have to confirm the diagnosis. You should not give to everybody coming with chest pain to ER. You should not give dual antiplatelet and consider it STEMI one way. No, we have differential. First, rule out aortic dissection because the treatment is very different. Aspirin and heparin will only make it worse. So you should not consider that everybody is having STEMI, and you should shift him to cath lab within 30 minutes, within 90 minutes, within 2 hours. This time for thrombolytic or for coronary angio will only start counting after you confirm, okay, this is a STEMI. So within this time, I need to give thrombolytic, or within that time, I will shift to cath lab. But before, even if it took you 30 minutes to confirm the diagnosis or to do CT aorta to rule out aortic dissection, this is not a waste of time. Actually, it is better for you and for your patient on the long term. Also, avoid GTN, morphine, and diuretic in inferior wall MI, especially with RV MI. Dyspnea, I will go quickly during this because we ran out of time. So as we said, acute dyspnea is much more dangerous. I need you to remember this mnemonic E first. So E for edema, pulmonary edema, and embolism. So pulmonary edema will cause acute dyspnea, pulmonary embolism will cause acute dyspnea. F is for fever and fear. In some patients, after you do your differential diagnosis, you will find that this dyspnea is from fever, and actually fever will cause tachycardia, and if pneumonia is there, it will cause also dyspnea. Fear also is an anxiety or panic attack, and this is a diagnosis of exclusion. You should not put it your first priority, but it should be in your list after excluding other causes. S is for shock and sepsis. Of course, if your patient is having shock, he will be gasping for breathing if the shock is bad. Same also for sepsis. If he is going into impending septic shock, he may have also some SOB. So you should be careful. T is for tension and tamponade. So tension pneumothorax and the cardiac tamponade, both will cause acute dyspnea. Tension pneumothorax, you diagnose by auscultation, palpation, percussion, and immediate chest X-ray, and you do needle decompression. Tamponade also, you suspect, you diagnose with big striate, you confirm with echo, and immediate pericardiocentesis. So the onset and the course of dyspnea is the key for diagnosis. We did not say what is A. A is anemia and acidosis. So anemia, if acute blood loss, this will cause dyspnea also. Acidosis as well. I remember one case came to ER. She was pregnant lady, 30 years, seen by some of the colleagues, and he told me that this patient dropped to ER, pregnant, SOB, they did ECG, there is nothing. They suspected pulmonary embolism, they did CT pulmonary angio, there was nothing, still patient is having dyspnea. Then some of the colleagues told them, I need blood gases. They did blood gases, pH was 7.1, metabolic acidosis. They did blood sugar, it was very high. So they diagnosed there as DKA, and this was the cause of head dyspnea. Acidosis will cause hyperventilation to counteract. So it should be in mind, patient with acidosis. I have also experience with this. I saw one patient coming with acute dyspnea. The ER doctor consulted me, he told me, come and see this patient having acute dyspnea. I don't know the reason. ECG is okay, chest X-ray is okay, but still the patient is uncomfortable. I saw him. He told me that he did renal transplant. So I told him, okay, we'll get blood gases. Chest examination is okay. Saturation is okay, but still the patient is dyspneic. Then the surprise, patient pH is 7.9, is 6.9, 7.1, and severe metabolic acidosis from renal origin. And it was most likely that he had graft rejection after renal transplant, and he got metabolic acidosis from renal etiology. So E for edema, pulmonary edema. Everybody knows pulmonary edema, embolism. F for fever and fear. A is for anemia and acidosis. S for sepsis and shock. T for tension and tamponade. As we said before, pulmonary edema, peripheral edema. Pulmonary edema either cardiogenic or non-cardiogenic. Non-cardiogenic pulmonary edema is ARDS. And actually it is a very bad condition, and also the diagnosis is very tricky. Usually these patients are diagnosed only after you ventilate them, you check BF ratio, then you will find that this patient having either acute lung injury or ARDS. So it is pulmonary edema is either cardiac or non-cardiac. CHF is not pulmonary edema, and here also some trick that chronic heart failure patient or congestive heart failure patient is not necessarily having acute pulmonary edema. When we say pulmonary edema, we mean lung full of crepes, desaturation, and unstable patient. Chronic heart failure may go with basal crepes through months or years of his lives. In MI patient also, we use KILIP class for grading heart failure and shock. From KILIP 1, who has no pulmonary edema, no heart failure. KILIP 4 is cardiogenic shock. KILIP 2 and 3 either basal crepes or full of crepes. The early use of BiPAP or CPAP reduces the mortality in such cases. Always consider in pulmonary edema the early use of CPAP or BiPAP. There is no harm like invasive ventilation. Actually, it is more beneficial for the patient than Lasix and nitrates. The only treatment that is proven to reduce mortality in pulmonary edema cases is BiPAP or CPAP. Lasix is symptomatic treatment. There is no effect on mortality. Same also for nitrates. ARDS or non-cardiogenic pulmonary edema is always the diagnosis of exclusion and they need high index of suspicion. After BiPAP or endotracheal tube, you do EPG and BF ratio. The only treatment that will help ARDS is ventilator also. Diuretics may help both conditions. Peripheral edema, think organ failure, heart failure, renal failure, liver failure, nutrition failure, I mean albumin, low albumin, lymph also, and vascular failure. As we said that sometimes the valves of the lower limb veins is the only problem. You check all these and still the patient is having edema in lower limb, so you diagnose by Doppler. If you of unilateral peripheral edema, think DVT, cellulitis, or some rare causes. Faint and syncope, I just want to remind with some few words that syncope, this is for sympathetic, parasympathetic, or vasovagal. N for neurogenic syncope, C for cardiogenic syncope, O for orthostatic syncope, and of course, BE can present with syncope and also psychogenic syncope or conversion reaction. So always the main priority here is to rule out cardiac syncope. Then, if it is vasovagal, no problem. Neurogenic, medical will take care. Pulmonary embolism also you will exclude during your workup. And orthostatic you can diagnose by checking blood pressure, recumbent, and standing. So cardiac syncope has to be ruled out in all cases. Half of cardiac syncope patients will die within a year if not appropriately management. Also, what is more important than ECG in syncope is the scenario itself, before and after and during the attack. So before the attack, what was there? After the attack, what was there? During the attack, if it is witnessed, also is very helpful. It is like epilepsy also. Before the attack, after the attack, and during the attack, what was there? If there is prodroma, this is points to vasovagal. If no prodroma, looks like cardiac. After the attack, if there is long time that the patient is unconscious, this is point to post-ictal, not cardiac syncope. Looks like epilepsy. And during the attack, if the patient was lying flat or sitting, this is very dangerous that he had syncope in this position. Usually vasovagal will come only if the patient is standing or certain situation. Look for the ECG also after syncope. You will find either ischemia or arrhythmia, short or long BR, HOCM, Brugada, ARVD. So ischemia and arrhythmia, everybody knows. Two that you should not miss during calculation, short BR and long BR and long QT. Three syndromes also like HOCM, Brugada syndrome, and ARVD. Echo is helpful in syncope to rule out structural heart disease like aortic stenosis and HOCM. And especially syncope also, exertional syncope or during exercise will point also to aortic stenosis, pulmonary stenosis, HOCM also. Family history also is important because if the patient told you that he has positive family history of sudden cardiac death, this is a worrying feature that you should look more and more to exclude some genetics. Head injury plus loss of consciousness, you need to do CT. So LOC in head injury equals CT. And not all LOCs are syncope. Sometimes if you have posterior circulation, TIA or stroke, you will have also loss of consciousness, but it is not syncope. General presentation, as we said before, fever, anorexia, headache, malaise. It may be pericarditis, myocarditis, endocarditis, or a mix of this condition. Endocarditis is bacteria with the focus in the heart. Not all patients with fever has endocarditis. This is very important. Look for focus in common places. So I remember also some scenarios that medical doctor is asking, I think this patient is having endocarditis. Why do you think? Because he's having fever. Okay, he has pneumonia. So why he will not have fever and why he will have endocarditis? Common thing is first. Then if you did not find, then we have to look for some other reason. Or if the patient is at high risk of endocarditis, then we have to look for. But we should not screen all the patient with fever to find endocarditis. This is not how it works. Once suspected endocarditis, you have to apply Duke criteria. This is also very important. So if you said, I think this patient is having endocarditis, okay, you apply Duke criteria. It will give you either definite, possible, probable, or a rejected case. So once you start antibiotics, the patient manifestation resolve within 4 days. This is a rejected case of endocarditis. Also, if you know that this patient has possible endocarditis or high likely or definite endocarditis, even if you did not find vegetation with echo, with bedside echo or departmental echo, you will do transesophageal because you know that it is endocarditis. You will keep looking for the vegetation. Even if you don't see it, you know it is present, but you cannot see it because of the Duke criteria. So actually, Duke criteria are very helpful in this scenario. Hemodynamic instability, as we said before, you can call it also pre-arrest scenario. Just Remember these words. Oh my God. O is for oxygen, M for monitor, connect to monitor, G for get help, get IV line, get random, blood sugar, and the blood gases. This will work for any sick patient. When you remember it, you apply it, then you will find it is more easy to handle the situation. Put oxygen for any acutely ill patient. If the patient is CO2 retainer, then you will find later and reduce. But for most of cases, there will be no harm to start oxygen for acutely ill patient. Again, for monitor, you have to connect any sick patient to monitor and get help, because you may need someone else like anesthesia. Your colleague also will help you. If the patient deteriorated and arrested, you will need someone for compression, someone for airway, someone for medication. IV line is very important. Even if the patient is having STEMI, you diagnosed based on ECG, but he did not put IV line, he cannot do coronary angio and he cannot get thrombolysis because you did not put IV line. What is the benefit of ECG with STEMI without an IV line? So put an IV line first, please. Then we will go further for the diagnosis and treatment. Again, for arrhythmia, if the patient is having rapid AFib, you rush for ECG, you did the ECG, there is rapid AFib, okay, this is great. Then we want to give some medication now. How we will give it? There is no IV line. So please, IV line is before ECG. And again, random blood sugar and the blood gases. This will give you like 80% of what you need to know and help your patient. If blood sugar is too low or too high, you have to manage also, because too low blood sugar can kill your patient even before you think of another diagnosis. Same also for blood gases. If you find the ABG is too much disturbed, you will know also either it is respiratory or metabolic, or the patient is too long time he's arrested or having some lactic acidosis or so. And also some ABG will give you electrolyte. So you'll know about renal function, you will know about respiratory function, you'll know about shock state with lactate. And as we said before, ACLS is mandatory for all cardiology.